C'est bon là?
We'll start our regular press briefing today with Dr. Nabarro, who's United Nations Secretary General Special Envoy on Ebola. As you all know, we'll give him 1 minute.
Good morning, colleagues, and sorry to be late with you today. I've just returned from 2 weeks in West Africa. It's my 4th visit to West Africa since I started working as Envoy. I visited Liberia, Sierra Leone, Guinea and Mali, and also spent some time in Accra at the headquarters of the United Nations mission on Ebola emergency response. I'm really inspired by what I've seen, what I've felt, what I've heard. The issues being addressed in the region are enormously complex and difficult and affecting thousands, causing a lot of suffering. But I believe that the response strategy being pursued by the governments with the support of the international community is right. It's working in quite large parts of the affected areas, and I've seen real progress compared with what I saw when I was there in August and in September. I want to start with focus on the national responses, the responses by the government and people of each of the affected countries. I've always said that in responding to a major disease outbreak, success depends on people themselves taking ownership of the problem, adapting the way they behave so that they reduce the risks they face, and also adapting the institutions that they have, their traditional institutions, their governmental institutions, so that they are able to respond. And in Liberia, for example, I saw the way in which a colleague who I've worked with for years, Talbot Nyenzwa, now coordinating a really effective incident management service, and indeed further developing it so that there will be a further IMS specifically for Montserrado County, which is where Monrovia sits. I was delighted with the way in which the National Ebola Response Centre in Sierra Leone is evolving. It's really advanced a long way, and Paulo Conte, the former Minister of Defence, who is leading it, is doing so with precision and also with care. And then in the Cellule for Coordination in Conakry, I was delighted to see how Dr. Sakoba Keita, who is the coordinator, is really now taking the whole of the issue very much in his hands, reporting directly to President Alpha Condé about progress. This strong national responsiveness shows me that the right route in all these kinds of problems is always to work in a way that supports the national authorities and that enables them to act. There were many questions asked of me about international support and how it's likely to evolve. There were many questions about whether international support will continue after the outbreak has finished with this kind of strong and directed effort. There were also signs of increasing synergy of the international response, a strong African response from the African Union and individual nations like Nigeria, Democratic Republic of Congo, Ethiopia, and also ECOWAS as a community. I saw much efforts by non-governmental groups working together, learning from each other about how best to run Ebola treatment units or how to ensure that community mobilization and case finding is done effectively. And perhaps that brings me to a couple of words about the response. It really is complicated. When I compare what we're having to do collectively on Ebola with some of the other public health activities in which I've been involved, this goes much, much further than a conventional program, because there are around 12 different critical actions that have to be undertaken in each community. And you need thousands of people to implement it. So it's a pretty big coordination challenge. So how do I describe the way in which people are working together? Answer, they have just made a decision, all of them, to try to fit together well. And if they have challenges, to try to overcome them well. There are odd cross moments, some of those are quite public, but all in all, the general sense is one of everybody wanting to work together, whether they're in the militaries, whether they're in the United Nations, whether they're in an NGO or in business. They want to find ways to work together. I saw such good examples in Nzerekore, in the interior of Guinea, local communities, Red Cross, World Food Programme, Médecins Sans Frontières, Alima, and other NGOs, African NGOs, European NGOs, all working together as one. And really very, very impressive. I'm very pleased with the way in which our UN family is upping the effort. I mean, the people who are working in the region have elected to go and do so, despite the fact that we can't give them absolute promises on their personal health and well-being. They do face risks, and so I would like to pick out UNICEF's work on social mobilization and community-based care, the World Food Programme with its work on food for isolated communities and also for a huge logistics operation, UNFPA on contact tracing, UN Women on the specific issues faced by women, which we know are considerable, and perhaps most importantly, the World Health Organization, which is providing the direction for the whole response. And we see an increasing number, hundreds of WHO people in the region, all trying to get on top of the epidemiology and contact tracing. And I like the way in which the UN mission for Ebola emergency response is now offering a means for directed coordination of not just the UN system, but others. Just back to Nzerekore, the doctor heading the treatment center is a doctor from Niamey in Niger, who I've known for years, who is an example of the kind of international solidarity that we see. And in fact, Nzerekore is a kind of mirror of the overall global response, built with money from the European Union and constructed through the efforts of the World Food Programme in 25 days of 24-hour working with Red Cross volunteers and others all there. I did say just now that communities are at the heart of response. You can't do this without local community involvement, and we see when local communities are particularly involved, then the response is always better. I'm delighted with the way in which the world continues to be engaged. Yesterday, UNMEER received 20,000 sets of personal protective equipment from Japan. 400 motorbikes arrived last week from Germany to bring blood samples to laboratories. And there are continued commitments coming in every week to the Secretary-General's Trust Fund, which is absolutely key. The African Union's $10 million donation, plus their willingness to make available hundreds of doctors, nurses, and other workers, is absolutely fantastic. And Nigeria, particularly recently recovering from its own outbreak, sending dozens of doctors in from Lagos. Now, our current focus is on a much more granular understanding of the outbreak, looking at each individual district or province or prefecture and seeing how the cases are evolving and also whether they are reducing or increasing in number. There are two particularly troublesome areas. One is Western Sierra Leone, which is Freetown and Port Loko particularly, where there is a need for a much more intense response. There's high levels of transmission, and we currently have some of the most experienced Ebola responders in the world working in that area, bringing together UNMEER, the government, different parts of the UN, the World Health Organization, obviously, many NGOs, to try to make sure we've got the beds and also the community mobilization and the burial teams there in adequate number to deal with what is quite a strong flare-up. The second area, which is a cause of trouble, is the northern part of the interior of Guinea, Guinea Forestière, and we have been working very closely with Mali to try to make sure that if cases per chance cross the border, that they can be dealt with very quickly. I was working with the President of Mali on that and with the UN peacekeepers in Mali. And so we're now focusing on dealing with these still quite inflamed areas where there's a lot of transmission, and at the same time in the other areas getting towards zero transmission and making certain that there's continued vigilance. And that's particularly the case for Liberia, and we talked with the President at length about how to maintain focus in that country. We do need continued numbers of foreign personnel to support governments with Ebola treatment units and holding centres, and also to do the local epidemiology. And we will need to maintain global attention and vigilance, because if it spreads to other countries, that will give us continued difficulty. Well, I'm very pleased indeed to be back here, because my interactions with all of you in this room and also your colleagues in other locations have been really constructive, and I'd like to try to respond to any questions you might have if I know the answers, and if I don't know the answers, I'll say so. So thanks very much for listening to me.
Yes, questions, Lisa?
Yeah. Hi, nice to see you again. I'd like... Okay. Could you be specific about the kind of more intense response that is needed in Sierra Leone? Sierra Leone has recently bypassed Liberia as the most heavily affected country in terms of Ebola. What has gone wrong there, or perhaps has never been put right? So if you could spell that out, because we hear about problems of quarantining people and so forth. And then essentially the same question in how you bring down the number of Ebola cases in the northern part of Guinea, these two trouble spots.
Thank you very much indeed. I would not like to characterize what is happening in any part of the region as something that has gone wrong. When we started out on the strategy that was developed in August, we knew that it was going to be an uneven process, that also that the virus has its own journey that it's following with the people who are infected, and that we would have to work hard to try to pull ahead and to be on top of it. And so it's no surprise to us that we have seen numbers of new cases a day coming down quite rapidly in some parts of the region, particularly in Liberia, outside Monrovia, and also in eastern Sierra Leone, which was an incredibly intense transmission zone in August and September. The increase in transmission in Western Sierra Leone is a reflection of the fact that communities there have yet to fully embrace the outbreak and to take action to avoid infection themselves. And also, we don't yet have the full number of functioning treatment centers and places for where people who are ill can be kept away from others. And so we are anticipating several hundred beds to come on stream in the next few weeks, and that will lead to the situation calming down. We're already seeing some suggestions that the numbers of new cases in parts of the West are not increasing at quite the same rate as they were 2 weeks ago. In order to move forward, therefore, what we are doing is encouraging the people who are staffing the treatment centres to gradually take more and more patients. We're finding ways to see whether or not patients who are in the treatment centres can be discharged a bit earlier. One of the ways to do that is to speed up the rate at which results of their second lab tests come through, and so there's a lot of work underway right now to improve access to laboratory testing in the western side and to speed up the movement of samples to laboratories. And then lastly, a big effort on social mobilization. UNMEER has sent what they call the Western Area Surge Team, picking some of the best people that we have throughout the whole region to work in the Freetown and districts around it to help take this forward. And the President of Sierra Leone himself last weekend, like Saturday, Sunday, was travelling around seeing what he could do to encourage everybody to work better together, meeting with the NGOs and others. So we're responding in the way that one might expect, with convening all the different actors, looking at the different problems, strong political engagement, bringing in our best people to help to make sure the pieces are all in place. And although I hate predictions, I am at least confident that unless something goes radically wrong, we will see an improvement there. It's a bit like what Monrovia was like 4 to 6 weeks ago, and I think that it will certainly calm down. Now, the interior of Guinea is a little bit more difficult because the areas where people are infected are extremely isolated, transportation is difficult, and we also don't have quite the number of groups working in that area that are working in other parts of the region. And so that is now very much the centre of my attention, is how to find more people to work there, and also how to make certain that we get the strongest possible community mobilisation in communities that are still quite scared about the problem. So that is the next area on which my colleagues and I will focus, Lisa.
Nina?
Hi, Nina Larson, AFP. I was wondering, when you say that the communities in Western Sierra Leone haven't quite embraced the outbreak, could you give some details on what it is? Like, is it not doing safe burials, not doing hand washing? I mean, what is it they're not doing correctly? And also, you mentioned the need for international staff still coming in. Have you seen has there been a slowdown? And also, how many people do we still need on the ground? Thanks.
In September, the President of Sierra Leone put a lot of emphasis on engaging the tribal chiefs in Sierra Leone, so that within each chiefdom there was a local community response. The chiefs briefed their people that when ill they should self-isolate, that they should attempt to get diagnosis as early as possible. If positive, they should undergo treatment, and the chiefs helped the communities to own the outbreak and also to start to introduce safer burial and healing practices. Western Sierra Leone is slightly different in both structure and also in ways of working. It's more urban, the communities are younger, and it is said that the chiefdom organization is less well developed, and it's very important there to embrace other groups, young groups of youth particularly, and that is what is happening in order to try to get greater awareness. It's also, because it's urbanized, the community structures are very different. The result is perhaps less the safe burial issue, though there have been some reports of unsafe burials that are a cause of concern, but it's more the practice of self-isolation, which is absolutely key, is one that needs to be put into place more. There are reports coming through of places where people who are sick, staying at home, and perhaps infecting their families. It's much easier in the traditional villages, to practice self-isolation than it is in these semi-urban areas. I mean, all this is shifting very fast indeed because of a big effort on mobilizing communities led by the President and led by local leaders. And so it's only a matter of time before we see the same community understanding as we've seen in eastern Sierra Leone and in Liberia. Secondly, on international staff, I don't think that I can report a slowdown. We're still having teams of international personnel coming in to staff up treatment units. What usually happens is that they come and they need to spend quite a lot of time in transition training and acclimatization to get used to the local working conditions. And that is an interval that is a bit unfortunate because it does mean that teams come in but still they can't get to work for a period of time. It's normal, by the way. And secondly, we now need an increasing number of epidemiologists and supervisors for case finding and contact tracing, and so it's those kinds of rather special international people that we're looking for. They're coming in, and they're coming in from all over the world, and I'm not sitting here saying we need to go on appealing intensively for them to come. What we need to do is to find ways to locate the people with the skills that are needed and to make certain that they are released from their current work and allowed to join. I think things might get difficult if this goes on for many more months and some of the people staffing treatment centres rotate out, and I still think that we will need a number of people to come in, and the people who have promised that they will come and staff treatment centres but haven't yet arrived, or will come and staff laboratories and haven't yet arrived. I don't want anything to happen that might cause them to change their minds, so we do need to keep making it clear that people are needed and needed urgently, and particularly if they've already promised that they're going to come and run a particular unit, don't hesitate, do come.
Marta?
Yes, good morning, Marta Hurtado, Spanish News Agency. You draw quite a positive picture there, but just the fact of the same related question as Nina once, the fact that 9 months afterwards the outbreak and 1 year after the first case arise, there's still people that doesn't embrace, as you phrase it, what Ebola means. Is not this a failure? Couldn't we say that something is missing, something is not doing it a proper way? Thank you.
Well, I think there will, of course, after this is complete, there will be lots of people who ask questions about, first of all, how the outbreak could have been avoided, and secondly, how the response could have been done more quickly. There will be. From my point of view, I simply can say, and the reason why I'm reasonably positive is that we've got thousands of people involved in the response. They are pretty well coordinated, and we have seen in many areas good progress, which means that the strategy works. But like you, I wish it was finishing more quickly, but I will not say to you that represents failure. I think it just represents a really, really tough job. I mean, I've been working, as you know, on other disease threats. For example, the threats posed by avian influenza, and these are still present in the world because of particular practices associated with poultry rearing. And you could say to me, well, haven't we failed that there is still avian influenza moving around and sometimes it affects people? Well, I would rather say it just shows we've got a tough job on our hands. We can start ascribing blame and perhaps saying that things have failed later when the full inquiries are done. But thanks for the question, because I think it's important we continue to ask questions, to learn lessons, and for me the big lesson of the last 2 months has been the absolute necessity for communities to be fully involved and to embrace the issue, just as we found with many other diseases. But on this one, we've seen that it is possible, and that when there is a little bit of reluctance for communities to be engaged, that a period of negotiation and confidence building is absolutely key. And where that's done well, it achieves results.
Stephanie?
Sorry. Reuters, can you say a little bit more about the situation of treatment centers in Western Sierra Leone? Specifically, you referred to a need for hundreds of beds that you thought would be coming in, and how it's matching up. Is it an issue of beds, or is it an issue of trained health workers not being there?
So thank you very much. The construction of beds in Western Sierra Leone for treatment has been led very much by partners, particularly the UK, as you would know. And the challenge has been to make sure that these are staffed by personnel who are experienced in Ebola care and who are able to do so without endangering themselves or endangering others. And for most of the new teams coming in to staff these centres, the process is that you open a centre and you increase the number of patients who can be admitted bit by bit. Because it's so dangerous, you don't open a centre and admit, say, 50 or 60 patients straight away. Even the most experienced Ebola care groups like Médecins Sans Frontières tend to build up, say, 5 or 10 patients per week as the staff demonstrate that they can follow protocols, and they have very careful supervision to check that there are not instances where there is a risk of people being exposed. And by staff, I mean lots of people. You need about 300 people to staff an Ebola treatment unit with more than 50 beds in it. These people have to be ready to change over about every 3 or 4 hours because of the heat inside the clothing. And each changeover is a dangerous moment, but also each interaction with the patients, particularly if it involves needles, is a dangerous moment as well. So the general line that we take is don't rush the process by which the staff increase the number of beds that they are ready to open. It must be they who decide, and especially if they're bringing together staff from lots of different places, that can take a bit longer. So that has been an issue. It's been quite widely reported in the press. This has been particularly around some of the newly opened centres in Western Sierra Leone. But I've talked now to several of the people who are running these centres, and they reassure me that they are now, particularly the ones that were opened in November early, they're now ready for 40 or 50 patient occupancy, which is very good. And that in turn means that the numbers of beds are increasing week on week in a good way. I hope that's okay.
Shin?
Shin from the national television of China. I was here last week, I think, with there was a press conference by Assistant Director General of WHO, Dr. Bruce Irewood. He came and with a very excited tone, claiming kind of an initial effectiveness. Let's not call it success, I guess. So there was a lot of excitement. People kind of thought that, wow, we met the goal, 70, 70, 60. I'm kind of surprised that by now nobody mentioned this goal during this press conference. What is your assessment of the situation, whether we achieved that goal in general or in some parts or not at all? And the Médecins Sans Frontières, they also had a very sharp critical piece saying the international response was slow, patchy, inadequate. What is your response to all that? Thank you.
You know, it's difficult for you, and sometimes it's difficult for us to talk about a process that's complicated and dangerous when we're very much in the middle of it. The 70% of people with Ebola under treatment, 70% of all burials safe and dignified by the beginning of December was a very, very important target because it helped everybody involved to focus on that very key task of taking the heat out of the outbreak and enabling more and more people who have the disease to access treatment. You have to remember that certainly when I was in the region in September at treatment centers in Liberia and even also in Guinea, there were terrible stories of people coming and trying to get treatment and being turned away to go back home because there was no spare capacity, or coming to get treatment, told that they couldn't get in, lying outside the treatment center hoping that a bed would come free, and really in a desperate situation. It was some of the most tragic experiences that I've ever had in my life. And so it's really important that when Bruce came here last week and said the 70% of people under treatment, 70% of burials safe targets have been both achieved in Liberia and in Guinea, and the burial safe has been achieved in Sierra Leone, and we're moving towards the treatment target in Sierra Leone. That really was a reason to feel good. And we do feel good about it, but at the same time, we know that the outbreak is still flaming strongly, as I say. It's still enflammé in French, in western Sierra Leone and in the some parts of the interior of Guinea. And so we can't rest, you know. We have to still push on. We can't sit back and say the job is even partially done, because of this fear that we have all the time that as long as there is infection in a part of the total area, that could easily spread. It could even spread to places where current infection levels are zero. And that keeps us very focused and sometimes quite anxious. Every day we wake up and we realize the enormity of the job that still lies ahead. So that's why I have a very great sense of satisfaction about what has been achieved, but I have an enormous sense of anticipation and duty about the work still to be done to reach the point where everybody is under treatment and then to reach the point where there is no further transmission. I hope that nuance makes sense to you. I want to say it's delightful to meet two colleagues from the Chinese Centers for Disease Control working in Liberia as advisor to UNMEER, and also in Sierra Leone with the National Ebola Response Center, and also to see the Chinese Center in Liberia working and able to receive patients, and also the Chinese assistance to the Trust Fund, and also the goods that have been provided by the government and people of China in the 4 phases. Thank you.
Thank you. Catherine.
Yes, Catherine Fiancon, France 24. Sir, you just said that you need an increasing number of people that have the skills to fight the virus, and also that you need 300 people in order to start an Ebola unit. Could you please be more precise about the people that you would need in order to fight properly the virus in the three countries and eventually also in Mali? Thank you.
Thank you very much indeed. Let me first of all explain what I mean about 300 people working in an Ebola treatment unit. The usual distribution is that there are 1/5 of the staff of a treatment unit that are international staff, and 4/5 are national staff. And so that means that you might have 50 or 60 international staff, and you might have 240 national staff. Increasingly, the proportion of national staff to international staff is increasing as we find more and more national personnel are really skillful at operating these treatment units in a safe and effective way. Indeed, in Guinea, the general pattern is increasingly that the international staff work as trainers and the national staff run the centres. And so what are the numbers and types of people who we seek to come and work in the region? Firstly, I want to stress that we seek people with differing skills, what we call clinical skills to treat patients. We need people with epidemiological skills to follow the disease and its progression. We need people with anthropological skills to help understand some of the challenges in the community. And we need people with managerial skills to help ensure that different parts of the response are properly managed. All of the people need to be very skillful teachers, because increasingly the whole effort is to teach national personnel, be they medical or non-medical. The people that we like are people who've done this kind of work before, not necessarily Ebola, but they've worked on infectious diseases, particularly in developing countries. And we also like people who can stay for 3 months or more. The numbers of people required is not so important as finding the right people and making certain that they're able to stay for long enough. And certainly anybody who's got these kinds of skills, who we can find, we do our best to bring them. We're really grateful to the African Union for the effort that they have done with countries in Africa to help locate French-speaking and English-speaking people with all these different skills, because really we have found that they are particularly effective at working in these situations, as I've already implied. I hope that's clear.
Thank you. Gabriela, I think that's going to be the last question. Gabriela?
Yes, thank you. Gabriela, Mexican News Agency. It's kind of follow-up. So to bring all this international staff on board, do you think that they need more incentives or better payment or things like that?
It's interesting, the international staff who are coming do accept that it is a risky environment in which to work, and also that a lot of them are doing this work because they feel an extraordinary sense of commitment and duty. There are people who want to come back again and again after their periods away. We used to worry that because we could not offer guaranteed medical evacuation if they were ill, that they would not come. We used to worry that because we could not offer guaranteed treatment if they got sick with common illnesses, that they wouldn't come. But what we're finding is the people who come are people who are prepared to accept that this is a really difficult environment, and they are prepared to commit themselves. They are really heroic people. Just as the national personnel who are working in health centres are heroic people. The 10th Sierra Leonean doctor to die of Ebola unfortunately passed away 2 days ago. And so my personal sense of real appreciation goes to the national and international people who are prepared to come and do this work, knowing that they put themselves at risk. So, frankly, they will come. The right people will come. They have to know that they'll be looked after by the international community, that we can make sure they get transport and accommodation if necessary. But they will come. Just a case of finding them and making certain that they know they're needed, because it requires a particular kind of commitment to do this work. And not everybody can do it. Thank you.
Thank you very much. I want to thank Mr. Nabarro for coming this morning. I think that's it.
Now you're going to do
the regular press briefing.
Thank you very much indeed. Enjoy the regular and have a good holiday moment, and look forward to seeing you again whenever the chance arises.